Hello, I'm honored to be here today to give a talk as a keynote address. I'd like to thank a committee member of AIOC for kind invitation. My name is Shizuka Ko from Osaka University, Japan. Let me start with this case. This patient received LASIK in 2009 and referred to us 3 years later. Although we didn't have any chance to access her preoperative information, probably her very early asymmetrical keratoconus signs might not be detected preoperatively by topography or tomography. Of course, this is a post-LASIK ectasia. Very early subclinical keratoconus is usually asymptomatic and can be undetected in routine clinical practice. In some cases, very asymmetric ectasia manifests clinically and topographically in only one eye. Such eye is called as formifrous keratoconus. Actually, this is the fellow eye of very asymmetric ectasia. This is defined as the fellow eye of very asymmetric keratoconus, which does not present with clinical or topographical signs, while one eye manifests with clinical keratoconus. However, there is no consensus on the definition of formifrous keratoconus. However, if both eyes of the patient have no clinical or topographical keratoconus signs and show borderline or abnormal values in corneal tomography or biomechanical assessment or other, how do you call them? Currently, there is no standard definition for such borderline cases. The terms such as bilateral form keratoconus could be proposed. This is a case of 21 years old female without any clinical sign. Her good visual acuity is good, and there is no significant abnormal findings in placido topographic maps in both eyes. But when we look at the shine-proof maps by a rotating shine-proof camera pentacam, there is some borderline and values in BADD in both eyes. Fourier analysis of corneal power by OCT can quantify corneal irregular stigmatism. Using anterior segment OCT, we recently reported that an asymmetric component in the posterior corneal surface is useful to discriminate FFKC from normal eyes. When we look at the Fourier analysis maps, there is no abnormal value in this case for both anterior and posterior corneal surfaces, so this eye should be okay. We do perform biomechanical assessment and also recently introduced tomographic biomechanical assessment as well. Shown here is a display from the Corvis ST by Oculus. So biomechanical index CBI and tomographic biomechanical index TBI are shown in both eyes. When we look, although BADD from both eyes are normal, but both CBI and TBI from both eyes are abnormal. Some subtle or mild corneal abnormalities might be overlooked before cataract surgery. In a recent study, 59% of the patients who were thought to have no pre-existing corneal or ocular surface abnormalities showed abnormal values on corneal curvature or biomechanics based on the refractive screening criteria during routine preoperative tests prior to cataract surgery. objective multimodal imaging is helpful in borderline cases. Shown here is my current cutoff criteria for normal eyes as the screening. We cannot rely on subjective judgments. I would like to share one interesting case. This is a 14-year-old female. So her visual acuities are very good in both eyes, and also there is no abnormal or borderline values in any topography or tomography or biomechanical assessment in her both eyes. Looks very good. However, her mother is clinical keratoconus. She is the third daughter of the three sisters, and her two elder sisters are already diagnosed with clinical or subclinical keratoconus. Therefore, this third daughter has high susceptibility of ectasia. Actually, she has eye-rubbing habit and atopy as well. So, she will never be a candidate for refractive surgery. Recently, ASCRS had published the review article about an algorithm for the preoperative diagnosis and treatment of ocular surface disorders. The important message of this paper is that dry eye may compromise results of corneal, cataract, and refractive surgery. As you know, placebo-based topographer uses the reflection of Meyer ring images projected onto the air tear film interface. So dry eye definitely affect the placebo topographic maps. Dry eye also may affect wavefront measurement as well. As you see here in the left side, deterioration can be observed in the wavefront soft pattern after the tear film breakup. And also in the right side, you can see the sequential wavefront measurement for normal eye and dry eye. You can see the visual deterioration after that with the time in dry eye. So preoperative diagnosis and treatment of dry eye is very important. Lastly, let me share a very simple and important tips. Fluorescence staining is a magic tool. Everybody can do it in every clinic everywhere. There is no need for special devices or invisible tests. We can assess the integrity of the corneal epithelium, and also it enables us visualize of tear film, tear breakup time, tear meniscus assessment, or Zydel test, and contact lens fittings are the example of visualization of tear film. Let me revisit the simple 3 steps in use of fluorescein. Number 1, apply the minimal amount of fluorescein. Number 2, shake well. Number 3, apply gently. This is a very, very simple 3 steps in use of fluorescein. In summary, please screen patient carefully to diagnose those who have an elevated risk for ectasia. And please check the ocular surface fully preoperatively to optimize preoperative measurements. It is very helpful to maximize postoperative outcomes and patient satisfaction. Thank you for your attention.
Thank you so much, Dr. Ko, for that comprehensive coverage. Thank you. Now we come to the session details, and the first speaker would be Dr. Chitra, who would be speaking on refractive lens exchange, when to and when not to.
ये डालना है क्या? हाँ हाँ, क्या हुआ वहाँ? Very good morning to one and all of you in this audience and the moderators on dais. I know I'm jumping the queue because I need to go back to my ARC programs, and thank you so much for this permission. My due is to talk on refractive lens exchange, when to do and when not to do. I think this is a very relevant topic because there has been an increasing interest on the part of the patients to get rid of their glasses, and they know that we have the technology for it, but are we allowed to do it, or are we going to burn our hands? Because the refractive lens exchange is not a treatment of pathology here, but rather it is about improving the visual performance. So the whole concept is different here. We do know we have the advanced biometry, we have the beyond the 4th generation formula which are available, which is getting us close to immetropic outcomes. We are lucky to have the laser refractive cataract platform also. I do not say that that is the only way you can go in for a clear lens exchange, but the criteria is you have to be excellent surgeon and you should be evaluating your post-op visual outcomes, and you know that you are consistently hitting the target, then you are poised for a clear lens exchange. And we do have premium IOLs today, which of course we have to titrate to the requirement of the patient. The 3 main categories where the patients may be interested are the low ametropes and presbyopes, those with very high refractive error where you cannot do a laser vision correction, or the AC depth is not adequate for an ICL, or those post-LASIK laser vision correction patients in the presbyopic age group who are anyway not wanting glasses, and now with the blur setting in, they are very much keen on getting a clear lens exchange. And are we justified to do it is the question. We have to really look very carefully at the ocular surface, be it the treatment of the dry eye status or anything which is there. The meibomian gland, which is not optimal, has to be taken care of. We need to look at the lens, the zonular status. We have to have an OCT done, look at the retina. And we need to understand that biometry is actually just a simple arithmetic. While there are some accurate measurements, there are a lot of assumptions here. Like if you see, when you're planning an IOL power calculation, the first thing which pops up is the axial length. Today with the optical biometers, we have unsurpassed accuracy. But when you feed in the post-op refraction which you want, the other variables which come up are the K which has to be entered and the effective lens position which has to be mentioned. We all clearly know that we are nowhere close to getting at the absolute accurate K measurements, and also we are off in our effective lens position, although the newer formulas have got more and more variables which tell us to get that close to assessing the effective lens position. For that we have the better formulas like the Barrett Universal 2 or the Hill RBF, and we have the facility for using the best of ocular biometers, optical biometers. So this is the first case scenario wherein the patient had a small refractive error for distance, but essentially he was not very comfortable for his intermediate vision and needed glasses for near vision. Then when you have an access to eye trace, how it helps you is that it has a component called the dysfunctional lens index, and if you look at that extreme right, that dysfunctional index less than 5 is the patient who would be having some amount of visual blur, scatter of light, lack of clarity, and this persistent patient who keeps coming back to you wanting to get rid of glasses, for all you know, he may be having that kind of a lens, dysfunctional lens index, where there is a quality of vision which has already sort of started going for him, which may urges him to come to you. And if you have an eye trace and it tells you that the dysfunctional lens index is 3 or 4, that might be one more reason to kick you off towards a clear lens exchange. We need to look at the amount of astigmatism, and the least amount of astigmatism needs to be corrected in these patients because the promise is to get them rid of glasses. If you have access to the laser cataract surgery, it's a very soft, nearly absent cataract or very early cataract. So you could plan a honeycomb kind of thing wherein you're not doing much of softening here. And you can see that the anterior chamber is completely stable. I'm just prizing apart the fragments which are already ready to be engulfed, and there is hardly any manipulation in there in the eye. Of course, we have the best of phaco machines today, which also keeps the anterior chamber stable. But more than anything else, there's literally this patient had a CD of 0 and we were able to place the lens in this, do the surgery, place the lens. Of course, you need to do a thorough cleanup. Viscoelastic has to be removed. The lens has to be centered to the Purkinje reflex. We should see that you have the ideal rexes overlap over the lens, because everything attributes to getting your optimal results, and the patient did well. Now, this is a second case when he is a very high myope. He had an inadequate anterior chamber depth for an ICL, and you could not do a LASIK in this case, and he was very much interested. You need to do a thorough retinal evaluation, and before you can even think of doing a cataract surgery in these eyes, and probably this is an area which I would never transgress easily, unless of course he has a PVD. But that doesn't mean that if he has a PVD that he is not going to have a retinal detachment, but the PVD is sort of encouraging. If he has a posterior cephaloma, you need to ensure that you use your optical biometers, because with the immersion you might measure a higher axial length. So, however, the good news here is these IOL parts are very small IOL parts. So, even if there's a little error in these lenses, the effective lens position is not so significantly impacted as it would be if you were to use a very high part IOL. But there are surgical challenges. This is a deep anterior chamber, and the cornea is large, so you might erroneously make a larger rexus and you could have an optic capture. You should go in with your infusion off. You should increase your IOP ramp. You should be prepared for a reverse pupillary block kind of situation. So that is why you should go in with your infusion off. You can just lift up the iris and that would release the pupillary block. Then you could do a hydrodelineation, because these are very soft cataracts. So you have the epinucleus, endonucleus, which easily comes off. You should do a thorough cortical cleanup. You should do a capsule polishing. In a high myope, you may have to place a CTR2, and all of these are very much mandated, and over and above, you can plan a toric IOL. The challenge is if it were an extreme axial length, a small eye, these are very high powered IOLs. A small change in the IOL can bring a huge refractive exchange. And in short eyes, we are never sure whether it's a shallow AC or a normal AC. That's a challenge there. We need to use adequate viscoelastic, but not overinflate these small eyes. There is possibility of positive vitreate pressure, so you should decongest these eyes, and you may have to customize IOLs or even plan a piggyback IOL. This particular patient had a 40 diopter IOL implanted in both eyes, but in the left eye, he ended up with a 6 diopter of residual. So we use the Nichamin's formula, wherein you need to multiply by 1.5, and a plus 6 diopter needed a 9 diopter lens. And so a large optic sulcoflex lens was planned, which has undulating haptics and a posterior curvature, which ensures there's a space between this and the primary lens. And the haptics of this lens has to be placed at right angles to what the original IOL was placed. The last slides I'm showing you. The third segment is a post-laser vision eye. He is very keen on getting a clear lens exchange, but you need to understand that 70% of our patients may have no dry eyes, but those 30% where the standard deviation is more than 2, you need to check for dry eye status. If there is dry eye, treat the dry eye before you promise to do him a surgery. You would have to do not just a routine topography, a tomography, because there's an altered ratio of the anterior posterior curvature. You have to use the best of the formulae and the toric IOL. You need to do a posterior segment examination, because these are high myopes, cannot be missed out. If you have access to eye trays, rule out higher order abrasions. Look at the angle alpha. Of course, with the modern lenses, the central optic zone is larger. So they do tolerate even an angle alpha more than 5 to even up to 8 is tolerable. But the higher order aberration should not be there. The cornea should be regular in the 3 mm optic zone. The topography has to be normal. And there is astigmatism in this eye. So you need to correct the astigmatism. And a trifocal toric was done for this particular patient, because he was not very bothered about the light dysphotopsia, which is seen in these diffractive lenses. But he did very well. And with the Varion overlay or any other imaging device, you would get near optimal. Most importantly, if it is a LASIK patient, you need to go to the LASIK mode, use the Barrett TrueK, TK, the latest formulae, and that is what is important. Finally, we have to be with the patient, look at the raw data, validate the measurements, choose the best formula, treat the astigmatism, look at the different choices of IOLs we have, and choose the right IOL which that patient is going to need. So it has to be the right patient, the right IOL, a perfect surgery. In that particular case, maybe a refractive lens exchange could be one of those choices you could offer to your patients to get him off glasses. Thank you very much.
Thanks, Chitra. I would like to invite Dr. Ramamurthy on concepts of Contoura.
This is going to be a fairly basic talk where I am going to introduce you to the concept behind Contoura vision. There are two major horses which we face today. One is the Contoura vision, another is SMILE. What exactly is... Okay. We have different treatment profiles in laser vision correction that is available to us. Plano scan, wavefront optimized, wavefront guided, topo guided, custom Q ablation. Over the years, all of them have found a place in our armamentarium as far as laser vision correction is concerned. When we started out in laser vision in the early 2000s, wavefront guided was the one which attracted maximum attention, where we used to customize our treatment apart from the refractive error and the aberrometry values. The basic premise was to calculate the amount of aberrations that are pre-existingly existing in the eye and try to correct them. The concept was not to prevent induction of aberrations, to correct the aberrations which was already existing there. We were not considering the Q value of the cornea or the peripheral corneal aberrations. And essentially the interest in wavefront guided ablation, the concept of supervision, 6.2, 6.3 vision, etc. went out of the window. And we all realized that more than the quantity of vision is the quality of vision is most important. Then came the concept of wavefront optimized treatment, where we are customizing laser treatment based on the unique keratometry and refraction values, where additional pulses are placed in the periphery of the cornea, where the effectivity of the excimer laser pulses is somewhat deficient, so as to end up with a fairly smooth regular cornea at the end of the treatment, irrespective of the amount of refractive error that you are treating. So that's what is called the aspheric ablation. And here the concept was not to correct the pre-existent aberrations, but not to induce aberrations during the treatment per se. And this is the one which has stayed with us now, and most other platforms that we have built today is based upon this. What are the advantages of wavefront guided over topo guided? Basically, in wavefront guided treatment, what we are essentially doing is to do the treatment on the surface of the cornea so as to smoothen out or flatten out the extremely steep cornea. If the cornea is like this, we are going to ablate only this portion of the cornea so as to smoothen it out and bring it of a uniform shape. But on the other hand, when you are talking about a topo-guided treatment, it's a bimodal treatment where you are not only treating the steeper part of the cornea to flatten it out, but you are also treating peripheral to the flatter part so as to steepen this. Because of this, the amount of tissue that's consumed by the topo-guided treatment is far less than the wavefront guided treatment. This is the way, this is just to explain this. This is the flatter part of the cornea, this is the steeper part of the cornea, this is the ablation profile where you directly ablate the steeper part of the cornea, and the ablation is applied peripheral to the flatter part of the cornea so that you end up with a fairly smooth cornea. The concept is not to correct the refractive error completely, but to smoothen out the cornea to improve the best corrected visual acuity. That was the concept of the topo-guided treatment, which has been available to us right from 2003 as a repair tool, and we ourselves have been using it for more than a decade and a half. So what are the advantages of the topo-guided treatment? Unlike wavefront aberrations, the aberrations on the surface of the cornea, which contribute to totally almost 90% of the total aberrations in the eye, are static. They are reproducible. They don't change with time. They don't change with accommodation. They don't change with aging. And we are able to get almost 22,000 points from the entire surface of the cornea. And based on this, based on the treatment on the corneal surface where most aberrations are situated, we treat. This is not affected, as I said, by age, pupil, size of the lens opacity, etc. More importantly, we take into consideration also the asphericity and the keratometry values. And the treatment is not centered on the pupil, but it's in the corneal vertex through which the patient actually sees. Inherent to Contoura vision is also cyclotorsion compensation and pupil centroid shift. These are the basic advantages of a topo-guided treatment and per se for the Contoura treatment. why exactly Contoura came into being was that when topo-guided treatment was already widely in practice in Asia Pacific and European region, Alcon went to FDA for approval of their topo-guided treatment for irregular corneas. FDA said if you're going to apply it to irregular corneas, first prove it to us that it's going to function quite effectively on regular corneas, and that's the reason this particular trial was started, where virgin untreated corneas were taken up for treatment using the topo-guided concept. So basically, the inputs for this particular treatment comes from either Placido-based systems like the Topo Laser Vario, or the Pentacam can also be the oculizer or a Pentacam. The Scheimpflug-based systems are not really useful this particular treatment. So the basic premise of this treatment is essentially the refractive data is taken out, and then you get the topographic map from the corneal surface, and both these data is combined together, and the EX500 or the 400 used for exactly treating the surface of the cornea to regularize it. So this is the topographic map. This is the ideal topography that we are trying to get, and this is the difference map. This is the ablation for correction of the higher aberrations that is needed. This is added on to the refractive data, and thus generating ablation pattern that needs to be applied on the cornea. In short, this is the manifest refraction of the patient, and this is the height data of the higher order aberration that's there in that particular cornea. These two are combined together. As you can see, the treatment plan is quite similar to what it would require for a treatment of the manifest refraction alone. That's because the higher order aberrations per se in a normal cornea only requires a minimal amount of treatment. This is the left eye of the same patient, demonstrating a similar concept. So what are the features of the Contoura? It corrects both the sphere and the cylinder, corrects corneal irregularities. Mind you, these are virgin corneas which have a good visual potential, so these corneal irregularities are not too much. Minimizes induction of spherical aberration because it's a wavefront optimized platform. Cyclotorsion compensation is inherent, centered on the corneal apex, because of which when you are talking about run-of-the-mill corneas or run-of-the-mill refractive errors, this seems to have all the good points in it. Corrects both the sphere and the cylinder, corrects corneal irregularities, minimizes induction of spherical aberration. So topography, so what the FDA study showed, that was which was conducted in 9 centers, that out of the 212 subjects who were taken up for treatment, where up to 9 diopters of myopia, 3 diopters of astigmatism was treated, the results were extremely encouraging. In the sense, almost 30% of the eyes gained 1 or more lines of post-operative uncorrected visual acuity at 3 months compared to pre-operative. Basically, these patients were cherry-picked so as that the aberrations were not too much. But this was the only treatment that had so far shown an improvement in the uncorrected visual acuity compared to the pre-operative best-corrected visual acuity. Almost 90% of the post-operative best-corrected visual acuity was equivalent or better than pre-operative best-corrected visual acuity. And 40% gained 1 or more lines in post-operative best-corrected acuity compared to the pre-operative spectral corrected visual acuity. We have been using this platform for almost 7 or 8 years. Here I just present you our initial study. When we did a contralateral eye study, we were not too enthusiastic about this Contoura platform initially. But then what it showed was 100 patients, 1 eye treated with wavefront optimized, 1 eye with Contoura, and 100% of the eyes undergoing Contoura had a postoperative residual spherical equivalent error of less than 0.5 diopters. On the other hand, the results were equally good with wavefront optimized, but is in the range of about 95%. And mimicking the FDA study, 30% of the eyes undergoing Contoura had more than 1 line improvement visual acuity. And the amount of induction of aberrations as far as coma and trefoil was concerned was much less with Contoura compared to wavefront optimized per se. Thank you so much for your kind attention. I invite Kumar to deliver his talk.
Thank you, Dr. Rama. I'm going to talk on role of microkeratome in today's era. So this is quite a personal thing. It's quite discussed today. We have smart pulse, which is excellent surface treatment modality. We have femtolaser. We can do lenticle extraction. So does microkeratome even play a role today at all? Okay, so is there any role for microkeratome? And this is my personal opinion. It's quite disputable regionally. So there are lots of microkeratomes 10 years back available. Today there are only 2 or 3 microkeratomes which are really available. You don't have an option of 20 microkeratomes and then you select one. But now you have option of more femto lasers and you can select one. Now there are almost 5 companies which make femto lasers, but there's only 1 or 2 companies which make microkeratome. So there is an advantage of microkeratome. Of course, it's easily available, but the choices of options of microkeratomes have reduced. It's more affordable than a femto. We know this because the cost of the blade is much lower than the cost of the pack. It's very good results over time. It's proven, it is stable, it is consistent. So if you think that you have a higher retreatment rate because you are using a microkeratome, it's not true. If your retreatment rate is high, it's mainly related to your laser, not your microkeratome or not your femto or not your any other technique. So it's portable. So many people have centers. You can carry a microkeratome and go away. But nowadays, there is even a femto laser which is portable. You can take it from one center to the other. And people are doing that quite easily. It's easy to use. The learning curve with the microkeratome is much lower. Advantages, the CMC is much lower than a femto. It's proven the test of time. Flap complications are known, but over time you know how to handle the flap complications if there are. So the incidence of flap complication over the number of years have dropped. Yes, we know that dry eyes are more. The biggest problem in the microkeratome cut is the difference between the flap to hinge ratio. So your flap diameter is X, your hinge ratio length is X, which is consistent in femto and not consistent in a microkeratome. And that's the reason why the flaps of the microkeratome, sometimes you'll have a big hinge, sometimes you'll have a small hinge, sometimes the flap moves right or left. This is the major disadvantage of the microkeratome besides the other problems. And there is a little learning curve. So let's look at the microkeratome. This is a microkeratome made by Pendula, which I'm still using. Me and Dr. Sri Ganesh started using this. Now I think she has already sold it off or not even so bothered to sell it off. But well, it works very, very well. I'm doing a 90 micron flap. The only disadvantage here, you have to use one blade per eye. You can't use the same blade in the other eye. You'll get a 70 micron flap. So there's a variation of 10 microns. This is a 90 micron flap. You'll see how smooth. So if you have an RK operated patient, if you have a patient with corneal opacity, it's better to do a microkeratome cut. I also do a microkeratome cut today if the patient wants to go to merchant navy or air force. Either you do surface or you do a microkeratome cut, because the microkeratome cut edge is not seen when you do it in any other patient if you use one blade per eye, but a femto cut will always be seen. So that's the difference. And let's look at the other side. So I have no control here. So this is a very, very old machine which is Moria. So originally I also used to have a Moria, and the Moria used to I also used to do a hand cut. So if you move your hand fast, because it's run by nitrogen cylinder, so the blade oscillation is decided how fast you move your hand. If you move your hand slowly, you get a thick cut. If you move your hand fast, you get a thinner cut. And that is the original Moria. So this was again a disposable Moria. This is still available. SBK nowadays also available. And then you used to put it into the motor, and then you have a locking mechanism. The first I did live surgery in one of the centers in Gujarat. I forgot to lock, and I had a beautiful free cap without a hinge. So in a way it was easy because there's no hinge, so there's no alignment. If you have a hinge, you still have to align. But this is the original Moria, which you have to, I just show a little bit and then I'll get out of this video. And this is how it used to be assembled. And then you put it into the suction ring and then you lock it. Once you lock it, you do a forward and a backward. And you can have a nasal hinge, you can have a superior hinge, you can decide whatever you want depending on how you put the suction ring, you can decide what you want. So this is the blade, and it used to work beautifully, but this Moria is no longer available now. It's only the SBK that they are selling. They don't make this anymore. So this was the assembly that was there. I'm not having the control to fast forward, but anyway, you used to mark. And once you mark, now this was the Moria. Wherever you put the arrow, you get your hinge. There are only 2-3 rings, +1, +2, H was for hyperopic. And once you've done this, just make your flap. And then I had a MEL 70. Some of you might not even know the existence of this laser. Then came the MEL 80, and then came the MEL 90. And today I'm using an Amaris. Before that I had an Osiris. So you'll see one suction ring being placed on the eye. And that suction ring worked as an active eye tracker. That was the beauty of the whole system. So we did not, today we have a 6-dimensional eye tracking, 7-dimensional eye tracking. 20 years back, I started LASIK in 1999. All that was not there. So we had only 2-dimensional eye tracking. Was the pupil plane, the X and Y, and nothing else was there. So here you can see that the flap is beautifully made. Just lift the flap and then you put a ring, and that ring would also protect your hinge. This is a ring. Okay, so the eye tracking was in the center of the ring. So if you misplace the ring, you'll have a decentered treatment. If you place the ring well, you have a well-centered treatment. Okay, this is how it used to work many years back. So it's just going back into history. So let's look at history. First came surface, which was PRK, where you used to remove the epithelium, then use alcohol. Then came LASIK blade, then came bladeless femto, and then we went back to surface. Okay, but here the epithelium is removed by the excimer itself. So studies of dry eyes, better confocal adhesing, knowing your basement membrane, anatomy layers, and now knowing the stromal fiber arrangement, understanding ectasia, science has evolved over the number of years. So all the options of surface, blade, bladeless, flapless, ICL, etc. is possible in today's era. But some centers I know in India, I know Sri Ganesh is one center does only surface. Okay, and only surface, bladeless lenticule, and no blade at all. I think Sri Ganesh does that, and some doctors do lenticule and or surface. So the choice is entirely yours, but I have an open center, so people come into the center, they use blade because it's more economical. So surface treatments have evolved over the number of years. No mechanical scraping, no alcohol is used. Femto has also evolved over the number of years. It's more reproducible, but you must know your white to white in a femto laser. You can make 90 micron flaps. Flap to hinge ratio is perfectly consistently the same. You can have the hinge in any direction you want, either you right or left or any, and the angulation in a femto can be managed. You can have a 70-degree side cut, you can have a 90-degree side cut. Highest I've done is a 150-degree side cut. Of course, the cost of the machine is more and the CMC of the machine goes up. So the answer, I personally feel it does still have some role, but surface and femto is the way the world is going. Thank you.
Morning again, or is it still not afternoon? So I'll be giving the first talk, which Dr. Sheetal had to give, but she had to run for a free paper presentation. So the talk is when to smile and when not to. And we have been doing smile for the past 10 years. Like Dr. Kumar said that we do surface ablation, but I've hardly done surface ablation. Mainly we do smiles. So we look at specific indications for smile, when to smile, when not to smile, and what are the advantages. So some of the specific indications are patients who want to place contact sports. Contact sports including boxing, wrestling, karate, football, all these are sports where if you have a flap in the eye, it is prone for flap dislocation. So either you select surface ablation or smile. We prefer smile because the visual recovery is faster and patient satisfaction is better. There's an 80% less side cut than a LASIK flap. So you can just do a 2 millimeter incision which is covered by the upper lid, and so the corneal surface is intact, and it's very good for people who want to do contact sports. So and of course you don't have any flap complications like microstray, flap dislocations, or epithelial ingrowth. You also have patients with pre-existing dryness, especially contact lens wearers. Most of the myopes are contact lens wearers and they come with some amount of pre-existing dryness. Also, many of these young patients are IT professionals who are looking at the screen for more than 6 hours a day, and this excessive screen time also gives rise to some amount of dryness. You can also have perimenopausal women due to hormonal changes who have dry eye, and we all know that with LASIK we increase the amount of dry eye. There are several studies comparing LASIK and SMILE which have shown that the corneal nerve regeneration is much better with SMILE, and this is from one of the studies by Professor Shimizu in Japan. where he showed that the 1 month post-op recovery and nerve regeneration is much better in SMILE than with LASIK. This is because there is less transaction of the upper corneal nerves. So you know that the corneal nerves enter somewhere at around 120 microns into the cornea. So especially if you have a deeper SMILE cap at 140 microns or 150 microns, then the incidence of dry eye is less. We did a study, and it's published also, comparing 160 micron cap to 100 micron cap, and we found that especially in the first 3 months, the dry eye was less with the 160 micron cap. I think Narayan Netralaya also has done a similar study where they found that thicker caps, again you have less dry eye. So that's, but with LASIK, of course, you transect the nerves, and then you have slower recovery of the dryness. Then the third indication is high myopia, more than 6 diopters, because here the corneal biomechanics are much better with SMILE, because when you cut a flap, then the flap does not contribute to the biomechanics of the biomechanical stability of the cornea, unlike SMILE. And so the biomechanics is not only about ectasia, it also is about long-term stability of the refraction. And if you have weaker corneal biomechanics, then you can have changes in the refraction. A 10-year study by Walter Secondo and group found that in high myopia, again, the SMILE was very stable, and the regression was only about minus 0.35 diopters in 10 years. So it shows very effective and stable procedure. And right now, SMILE is approved for up to 12 diopters of spherical equivalent commercially, and up to 10 diopters of myopia. If you look at the zone of flattening, we also did a study where we found that the zone of flattening, so what is attempted versus achieved flattening by doing differential maps, pre and post-op keratometric differential maps, tangential maps, we found that the zone of flattening on an average with LASIK was about 69%, whereas with SMILE it was about 80%. So you get effectively larger optical zones with SMILE, and this helps in better night vision. And also many of these myopes have large pupils, and so when you have a large pupil and you have a small optical zone, then there's a higher incidence of spherical abrasion. This was a study done by Ektet Chansui from Thailand, and he found that if you look at the induced abrasion, the red is optimized LASIK and the blue is SMILE. With SMILE, the amount of induced spherical abrasion is much lower than optimized LASIK, especially so with increasing refractive errors. So here this is about 10 diopters. So you can see that starting from 1 diopter to 10 diopters. And with SMILE, with LASIK, the spherical abrasion increases. So again, night vision, night myopia is more common with LASIK and large pupils. Why does this happen? This is because excimer-based procedures have loss of energy in the periphery, what is called as the cosine effect or the summer-winter effect. There is fluence projection losses in the periphery, because in the center the beam is round, but as it goes to the periphery it becomes elliptical. There's a lot of energy loss, and so the ablation is not adequate. So you don't get a aspheric cornea. That's why in wavefront optimized they give extra spots in the periphery to compensate for this. But whereas with SMILE you have, so this is the induced abrasion and the abnormal corneal shape. Whereas with SMILE you have a clean excision of the tissue, there is no loss of energy in the periphery, and the natural aspheric corneal shape is preserved. Of course, SMILE has its limitations. So what are the limitations? There is no automated cyclotorsion compensation, and because of this, treating high cylinders you can have some amount of residual astigmatism, so you always have to mark. Again, large angle kappa you cannot compensate for this, but usually the patient is fixating on the visual axis. Dr. Pooja, I have my talk also, followed by this. So hyperopic correction right now is not present, and mixed astigmatism cannot be treated. Wavefront and topography based procedures are not available. Enhancement can be done either by LASIK or PRK. Smile on smile is not commercially available. But we did a study and published this in JRS, results of intraoperative manual cyclotorsion compensation for astigmatism, and found that results are very good if you do that. And we also described the way to compensate. So you mark the 0 180 degree axis, and then you can, after suction, you can rotate the cone and align the reference axis. So then you don't have, then the correction of astigmatism is better. The Visumax 800 has pattern rotation, and it will shortly be automated. So this takes care of this. And centration guide is very important, especially for large angle kappa. Here is eye with a large angle kappa, and you can see that there's a difference between the line of sight and the pupil center. This is on the Visumax 500. The patient usually fixates along the visual axis, so there's not a problem. With the 800, you have a assistance of the central line, where you can actually identify the visual axis and then center on the visual axis. So then you get a very good centration. This is a case of a large angle kappa, almost 600 microns. You can see the difference there between the pupillary axis and the visual axis, and it was treated on the visual axis. And you can see this is the post-op topography, and the patient had 6/5 vision uncorrected 2 weeks after the procedure. For mixed astigmatism, right now there's no commercial software, but we have an open software, so we treated mixed astigmatism also, and then this was like plus 3.3 with minus 4.15, and this was the surgical video. You use a hyperopic license, you use a medium cone, and then you can treat this. You look at the pattern, so you can see that it's very different from your usual smile pattern. And okay, this is how you treat mixed astigmatism. We have treated about 13 eyes, and then we'll shortly be publishing the results. That's the cap cut. But let me go on to the topography. You can see that this is the topography, this is the pre-op and the post-op, and the difference map. In the difference map, you can see the nice correction of the astigmatism. Hyperopia is just now getting CE approved, and we were part of the global trials for hyperopia, and I'll show you one of the examples. This was 21-year-old female, 5.5 diopters of sphere, and post-op you can see the correction. It was plano with 0.25 cylinder, uncorrected vision of 6.6. This is the difference map, and you can see the nice steepening here. This is pre-op and post-op, nice steepening of the central cornea. So one day most refractive surgeries will be smile, and there'll be very less contraindications for smile. Thank you very much for your attention, and I think can you bring up my talk, please? We'll go on to the next talk, which is basically on
So how many of us sitting here are actually doing smile or equivalent? 1, 2, 3, 4, 5. So Shri Ganesh, you have a long way to go. There are only 5 people doing smile here.
smile, yeah, but that's why this talk is there, so that I can convince them. And
So in any case, I am also a firm believer that small incisional lenticular extraction, whatever is being said, has improved by leaps and bounds, and you get exceptionally good vision, and good biomechanical stability is preserved, and all the companies are moving towards it. As of today, the Visumax 500 has gone down to Visumax 800, and you have Zimmer, the Z8, where you're doing clear. Then you have the ATOS, which is by Schwind, which also does the lenticular extraction, and just now there has been limited market release of J&J Vision's Elita, which they call as Silk. So these are the various machines which are available. Alcon also tried their hand, but I think they have aborted that trial for the lenticle extraction. But these are the 4 companies which are commercially available. I would say J&J would be commercially available very soon, but limited market release at 4 centers has been done. So overall, I think with less dry eye, better biomechanical stability, and exceptional results, getting 20/20 next day in a very significant percentage of patients is something that's driving the growth of the lenticle extraction. And all over the body, wherever you've gone on to small incision, whether it be laparoscopic, say cholecystectomy or anything, or you're looking at extracapsular going on to phacoemulsification, small is in, and that obviously gives better wound healing and better control on what you want. Yeah, go ahead, Shri.
Yeah, thank you.
Yeah, sorry? Hanji. Yeah. Any? I can talk about it. I think she and us, I have been working on it for 3 years. It has been given the FDA approval also now for the flap, not for the lenticule, but it has C certification for the lenticule also. So they'll be commercially releasing. So it's limited market releases just before they start commercially selling. So there are 4 units, I think. They have one, we have one. There is one with Schroff's, and I think one in IQ. So there are 4 units in India, and Singapore has it, Hong Kong has it, Australia has it, so Europe has it. So there are studies, and also IDE investigations have started in the US. So pretty soon the results are pretty good, and I think that should be available commercially. Hanji. It's like anybody who has used an intralaser, it's similar. That as of now there is a 2-piece patient interface, and I think within the next 4 to 6 months it's going to be a single-piece patient interface. It's a hard dock. You don't lose suction, and the time taken is about 16 seconds for the lenticule. It's similar as you have in all. There are the 4 steps of the lenticule. The entry cut is never a problem. It's fantastic, and there is minimal tissue dissection that we have to do. In the X number of cases, I think combined we have done about 300-400 or maybe more. I don't remember the exact number. NN was the other site that was doing it. We have not had any retained lenticle or anything which was considered to be a bugbear, etc. And more than 70% of our patients were 20/20 next day. Yeah, and we were, as of now, the cyclotorsion compensation is by marking, and you can see the marking. It's like the intralace. There's the GUI, so you can do the centration as also the cyclotortion. The IOL Master 700 is linked up with the Visumax 800 to do the centration and the cyclotortion. That was one of the criticisms that was being done. None of the machines as of today can do a smile equivalent on a smile for retreatment. So you have the option of doing what is called as a circle scan, where you make the cap into a flap and then do an excimer, or you do a surface ablation. Yeah.
Problem is with the finances. This is a thing which is holding the lesser number of installations. It's not the science, but it's the finance.
Yes, I think obviously
there are a lot of issues. It's not as simple as that, as the finance, because technique also is important. Nomograms, energy optimization. If you want to have similar results as LASIK and you want to have a wow factor, then you need to optimize your laser, you need to optimize the energy. There's a lot to be understood on the technicalities and also the technique of the surgery. It is because it is more challenging than doing a PRK or a LASIK, and there is a learning curve to extracting the lenticule. But of course, cost-wise, yes, technology is expensive. So as you have newer technologies, it will cost more, but with time the cost will come down.
So even the new machines, they are pricing it dearer to 4 crore. So that is the thing. And then the patient interface cost is still on the higher side. So you're right on that. But what Shri has said, so basically you have the energy, you have the spot separation and the lines separation. So these are the things that you have to do. And basically you want the least amount of energy with no cold spots and with no great OBL. So you have to have a gentle tissue dissection which is there. If you struggle with it, the eyes don't remain that quiet. And as he said, there normally there is a slight undercorrection in all the nomograms, and there has to be a nomogram adjustment. Even in this silk, we have done one set of nomogram adjustment, and then on the higher powers of myopia, we are doing the second set of nomogram adjustments, which we have just started the work on. So yes, there are more to it, but I think in once you are set on it, it's really a fantastic technique. Go ahead, Shri.
Yeah.
He'll be
So
doing,
I'll be talking on
Sheetal's talk, right?
No, that was Sheetal's talk.
Okay, that was Sheetal. Okay.
This is my talk on phakic lenses, expanding indications. So, how many of y'all are doing phakic IOLs? Okay, many more than Smile, so that's good. I am a consultant to Carl Zeiss, Meditech, Biotech, and also Star. So we all know that the indications for phakic IOLs, you can treat if it's ICL, if it's the EVO with the central hole, you can treat from minus 0.5 to minus 18, correction of myopia. And if it is a toric, minus 0.5 to minus 18 with up to 6 diopters of SIL in 0.5 steps. And with the other Indian phakic IOLs, you can treat up till 21 diopters. For the hyperopic ICL, you can treat from 0.5 to 10 diopters of sphere and up till 6 diopters of SIL. And but you need peripheral iridotomies. For the hyperopic ICL, you don't have the center flow. So if you let us look at the expanded indications. So we all know that we can treat myopia, myopic astigmatism, and hyperopia, and it is very suitable for high range of refractive errors. But some of the expanded indications are, one is bioptics, which is a combination of a phakic IOL with LASIK, SMILE or PRK for very high myopia. And this was first described by Roberto Zaldivar. Then you can also treat keratoconus, though keratoconus the company says is a contraindication, but we have been treating keratoconus, stable keratoconus with the best corrected vision of better than 6/12. These patients do well. And you can also combine it either after C3R, intrastromal rings or topo-guided PRK. And then when you have the residual power, you can correct it with the phakic IOL. You can also use it to correct high astigmatism following penetrating keratoplasty or DALK, and these are cases where you get residual refractive error, and sometimes you can get a surprise and a high cylinder, and though you have done an excellent job, the patient is not happy because of the refractive error. You can also correct presbyopia, and these are the newer lenses which are available. You can of course do a monovision phakic IOL, and that is what I do and prefer for most presbyopic patients. But you also have presbyopic phakic IOLs. You have the one from IOCare, which is basically a diffractive lens, and then you have the EDOF lens from Star, which they call the Vivo. That is the Vivo ICL. And the other indication is pediatric phakic IOL for correction of high anisometropia and amblyopia reversal, and this works very well. I have done about 12 cases of pediatric phakic IOL, and they do very well. You can also use the phakic IOL as a piggyback lens to correct any residual pseudophakic error. So this is a case of bioptics with SMILE. So first we are putting in the lens to correct the myopia, and you can correct myopia of up till 19 diopters with the ICL. So you correct whatever is maximum is possible, and then after 3 weeks you can dock and then do a SMILE treatment to correct the residual myopia and astigmatism. And we did a series, and then that is the lenticule extraction. This is my technique of lenticuloschisis, where it's a no dissection technique. You just hold the lenticule and grasp it, and then you can just, like a rhexis, you just pull it and then you can extract it. And this technique also has been published in the GRS. Of course, you need to optimize your energy. And we published the results of the bioptics in GRS. This is for keratoconus, where we are treating after implantation of Keraring and C3R. You wait for about 3 months, 3 to 6 months, and then the residual power is being corrected. You can see here I'm using a toric ICL. And you can regularize the cornea with the intrastromal rings, stabilize it with C3R, and usually the best corrected vision is better than 6/12. If the vision is less, best corrected vision is less than 6/12, then the patient satisfaction is not good. So that's why you correct any irregularities, you regularize the cone and then do the ICL. This is a post-DALC ICL. You can see the DALC here, and then this patient had astigmatism, high astigmatism, so we are using a toric ICL, and then I'm using the Callisto on the Lumera 800, the RTO, and placing the, you can see the Z align there. It has to be placed at 163 degrees. So this is a markerless system which we use both for toric IOL and the Phakic toric, and you can see the optical zone here, and of course this is the rescan. So you can see the, I just wanted to show the incision and also the DALC here. This was a pediatric ICL, a 9-year-old boy having high myopic astigmatism, anisometropia in the right eye with amblyopia, and we did a toric ICL in 2008. His refraction was -13 with 3 sil. Spectacle best corrected vision was 6/36, and we implanted a -22.5 diopter plus 5.5, and under intravenous general anesthesia, and did a peripheral iridectomy. This was before the center flow. Post-op vision improved to 6/9 after amblyopia therapy after 6 months. So we find that the amblyopia reversal is excellent in these cases of very high myopia with anisometropia. So this was the pediatric ICL. We usually give intravenous anesthetic because it's a very short procedure, so you don't have to intubate also. So it just takes like a couple of minutes. And you can see this was 2008. That's when you used to get higher power ICLs. We didn't have the markerless system, so positioning it with the Mendes marker, and I usually put one suture so that the wound is safer. So those were a few of the extended indications for the ICL. Thank you very much. If there are any questions, I can take them, and Pooja is setting up her talk.
Thank you, Shri. Yeah, Ritu.
Can I ask, how's your experience with the presbyopic phakic IOLs?
See, basically, I don't like the diffractive ones because you have a lot of night vision issues, and these patients want good vision. So I prefer to do a monovision, and the monovision, if you just do one diopter, it is good enough, because most of these phakic IOLs have image magnification, and 60% of them have improvement in the best corrected vision. So if you just have one diopter of anisometropia, the non-dominant eye, make it myopic by one diopter, these patients are extremely happy. And what I've seen is, I've been implanting ICLs from 2002, and many of these patients have become presbyopic now. They are in the presbyopic age, but they don't require reading glasses, probably because of the image magnification, and some of them have a slight progression of the myopia, the very high myopes. So they have like about 0.5, 0.75, and they are comfortable both for distance and reading, and usually don't wear glasses. But if you have a presbyopic patient who is a high myope, then the monovision works very well. They are able to tolerate it. The one from Star is basically a need-off lens.
Need-off.
It doesn't have the rings, but again, there is limited experience. I don't know India whether it is available as yet, but
no,
it should be.
I think it will take another 6 to 8 months.
The Viva should be introduced shortly. So
any experience in pseudophakic patients where you've got a monofocal lens and you've put a...
Yeah.
I have done that.
Pseudophakic patients, I use it to correct refractive, residual refractive errors, either a cylinder or a sphere. But
for a patient who is wanting
multifocality, again, you can do a monovision, but I don't know how well maybe the diffractive lenses from IOCare may work, but I have no experience.
Thank you.
I was talking about high ametropia for a pseudophakic patient whom I operated 20 years ago as a congenital cataract. So that patient had a -17, -18 refractive error. So I used an ICL because Rayner circumflex you don't get in those powers. So I used an ICL to correct the ametropia. There was a lot of fibrosis of the capsule and things like that. So I couldn't do an explant. Either I went in for a glued IOL or I put this as a piggyback. So I have used the ICL as a piggyback, but I'm not talking about the multifocal or anything like that. I think the EDOF lens by Star is going to take about 6 to 8 months more. They've applied because all of them come under medical devices and each one of them has to be certified by the DGCA. So that's why it's taking a little while.
They launched it in the last ESCRS. It's called the Viva.
Viva, yeah. No, there was a big noise even in US at the Ascaris. There was a big noise about it. Yeah, go ahead.
See, basically, this is for patients who have a clear lens.
Yeah.
And if you have the center flow, then the incidence of cataract is quite low. Cataract which happens in ICL is more of an anterior subcapsular rather than nuclear sclerosis. But once you open the eye, then there is definitely a higher incidence of nuclear sclerosis.
No, what he is
many
saying
of these
is
patients,
he is talking that basically they are above 40. So would you prefer a prelex? So the only thing is that if you are looking at a very high myope, the RD incidence, etc., could be this thing. So
that and of course, if you have a diffractive lens, then night vision issues can be there.
So EDOF doesn't give that kind of reading ability. It's the same like you have, like what you have today, a Vivity, or you had the Symphony. So basically they are there, but they are. I personally don't do a lot of EDOF. I feel iHands gives you as good intermediate kind of a vision with a slight mono vision you can actually get. So EDOF is, I don't know.
But these are early. See, these are early presbyopes, 40 to 50 years, early presbyopes with high myopia. So even that little bit of, one diopter of depth of field which they get is good enough for them to kind of manage without the reading glasses. So that is the principle on which it's kind of, but whereas if you do a refractive lens exchange, then you have other risks, detachment, CME, PCO, all these issues that come in. Plus they have the diffractive rings, which the night vision is not so good. So it might be, but I personally prefer to do a monovision, one diopter of monovision. These patients are extremely happy.
Thank you very much, Dr. Shirignesh. I think we still have, you have a talk? Next session. Okay. So there are two more talks. Dr. Pooja is going to talk about surface ablation and then I'll talk about extra. So go ahead.
Thank you, sir. So Dr. GAURAV LUTHRA couldn't be here because he's unwell. So he requested me and I will be covering his talk. And I would like to thank the entire AIOS for having us here. So today's talk is going to be surface ablation 30 years and beyond. So why surface ablation has still been around while we are talking about newer technologies like LASIK in that femtosecond microkeratome and also SMILE procedures. So this is how the evolution of LASIK surgery has been. We started with excimer laser, which was the PRK, and now we are talking about SMILE and Phakic IOLs. But PRK does come into picture when your corneas are destable or they are biomechanically weaker, they are thin, or they are extremely steep or flat corneas, or where your corneal thicknesses are a little borderline, or when you're doing the refractive surgery and your RSBs are towards lower side, or the patients who are into predisposition to trauma like contact sports, or they have to go into army. That's when PRK does come into role. And there is no doubt about it that it is the best, and we have the least chances of ectasias when it comes to photorefractive keratectomies. We have various machines which can give us, where we can operate. PRKs can be done on all the machines, but trans PRK is a procedure which is a no cut, no touch technique, where the epithelium is also removed along with the laser. And you don't have to use any blades or any manual scrapers to remove the epithelium. So trans PRK is one of the very good options, and the machine and it causes least chances of pain, haze, and it has very faster recovery rates. And the aberration profiles also with trans PRKs are much better compared to that of manual PRKs or with any two-step PRKs. The trans PRKs, which is a one-step procedure right now, are offered by two machines, which is the Schwind Amaris 1050 and the Streamlight on wave Alcon Wavelight. And the principles in both the machines are a little bit different. Schwind Amaris is the smart surf laser, where it's a reverse trans PRK, where it corrects the power first and then removes the epithelium. Whereas in Alcon Wavelight, it's a straightforward procedure where it removes the epithelium followed by the stromal ablation for the power correction, and it has an aspheric aberration profile. So our group has published work on polarization sensitivity, where you can actually image the stroma, the collagen, how the collagen orientation is, how the collagen density is, and whether it's a good collagen, whether it's a weak collagen. So we compared that. We wanted to answer that whether there is a difference between PRK, SMILE, and LASIK. And what we saw was that in PRK, if you see different depths, like how the collagen is at 90 microns, 100 microns, 110 microns, and beyond, what we saw was that post-surgery, there was nil or minimal change in PRK compared to that of SMILE and LASIK. LASIK and SMILE did equally, there was collagen remodeling post-surgery, but PRK caused nil or minimal change when compared to that of a healthy eye where there was no surgery done. So this is a classic proof that yes, PRK is the most stable procedure when it comes to biomechanically weak corneas or corneas where they are thinner or where there are any suspicious topographies present. PRK is a way to go forward. So this is a simple, this is a video of how PRK is done. This is a I think it's not playing, but the laser only removes the epithelium and stroma, and then if any refractive error is about 2 diopters, then you apply mitomycin C for 0.02% for every diopter 10 seconds, and that is after that you give a thorough wash. Just to make sure that there is no MMC related damage on your cornea or on the limbal stem cells. So that is why mitomycin C application has to be done to prevent haze. And if you are using mitomycin C, please do a thorough wash. And for every diopter, you apply mitomycin C for 10 seconds. So, but why is PRK not the most, in spite of being the most safest, why is it not the most popular procedure in market? So one is the pain, like there is fear of pain. You are removing the epithelium, and epithelium does take 2 to 3 days for it to heal, and that's when patients might experience pain. So that is one of the fear factor. Nobody now, no patient want to have pain today, but that is the first concern, and the second concern is the corneal haze. So let's talk about pain. Pain is there because of the exposure of nerve endings and enhanced spontaneous activity of injured nerve fibers and release of prostaglandins and neuropeptides. There are BCLs, topical medications and oral medications present, but they all have its own challenges. So can we make the topical pharmacotherapy safer? We used ketorolac soaked BCLs where we clean the surface, we injected the ketorolac solution in the contact lens pack, and after 5 minutes we applied the same contact lens on the patient's eye, and we could reduce the pain with conventional with ketorolac soaked BCL from 8 to 2. So this did reduce average pain scores, but ketorolac solutions are not always available. So is there any other technique? Yes, you can use a cold BCL. You can refrigerate the BCL overnight in the refrigerator, and then just when you're doing the surgery, remove that BCL and place it on patient's eye, and the pain control with cold BCL is as good or better than ketorolac soaked BCL. And next day when patients walk into your clinic, their pain scores are like 0 or 2, and their eyes are equally quiet to what you would see in LASIK or SMILE, and they have minimal pain. So the acceptance of PRK procedure because of pain actually improves here. The second concern is the corneal haze. Now, why does corneal haze happen? This is how the normal post-refractive surgery normal wound healing happens. Whenever you do a PRK, the keratocytes do get activated, and then they get converted to myofibroblasts and fibroblasts, and then because of the normal wound healing procedure, they will get apoptotized and there will be a normal wound healing. However, if there is any inflammation present to begin with, there will be excessive activation of keratocytes, which will get converted to myofibroblasts and fibroblasts, and that is how it will lead to haze. There will not be this myofibroblast, and myofibroblast will not die on its own, but it will lead to aberrant collagen, which will depict as haze. So our group has worked on this perfect protocol where we have a very good scoring system where what we do pre-op, intra-op, and post-op. It's available freely on IGO. You can download it, and the main aim of this protocol is to control the inflammation, by treating vitamin Ds. If your vitamin Ds are lower, then you need to treat patients with vitamin D because it reduces the inflammation and thus reduces the scarring. If the patients are contact lens intolerant, or if patients have, because of time I'm going to skip the slides, but if the patients are contact lens intolerant or the patients have any pre-existing dry eye or meibomian gland dysfunction, then always pre-treat these patients with anti-inflammatory agents, steroids, lubricating drops, and a short course of cyclosporin, and then take the patients up for surgery. And of course, keep in mind about the occupation of the patients, because if the patients are indoor, then it's not a problem. But if they are outdoor and they're going to be exposed to UV radiations, then please tell them to wear UV protective sunglasses for at least 6 months to 1 year after surgery to prevent haze, and tell them why they're doing it. They will not understand why they're doing it, but if you explain to them that why they need the UV protective sunglasses, the acceptance will be better, and then that's how also you can reduce the chances of haze. So this is again published in IJO. You can freely download it. There is a scoring system. If the score is less than 5, you can take up the patient for surgery. But if there is a moderate to high score, then you pre-treat the inflammation with doxycycline, steroid eye drop, cyclosporin, and treat vitamin D. And after 1 week, you can take them up for surgery. And post-operative also, the steroid regimen will be little bit more stricter than other patients. We give prednisolone-based drops for 1 month, followed by loteprednolone, sodium hyaluronate-based lubricant, cyclosporin for at least 6 months, and treat the nutrition, because vitamin D can cause inflammation in the eye. So to summarize, PRK is the first excimer laser which was approved by FDA. It is less destabilizing to the cornea, suitable in thin, steep, and flat corneas. With advanced technologies, it is faster, safer, more effective, and customization is possible. And with implementation of targeted specific therapies, pain and haze can be minimized. So as PRK is the safest procedure, as we all know, with this protocol, you can do it safely and maximize potential for as many patients as possible. Thank you. Ma'am, we correct in our institute until 6 or 7 diopters, but outside there are reports that doctors still are correcting till 8 or 10 diopters as well. But our recommendation would be not to go beyond 6 or 7 diopters. Raja number is concerned, then you will first see why you are opting for PRK. If it was a suspicious topography, if it's a mild suspicious topography, you can opt for a smile extra. But if it's a higher refractive error, then Phakic IOL would be the best option. Actually, as mentioned, like people are doing it for at least 10 diopters also. So haze is not specifically because of how much tissue you burn. It is because of your ocular surface health. So you can go ahead and do it. But some reports have also suggested that haze can be because of higher ablation. So just to be on the safer side.
So we normally restrict it to 6. I don't do it. Anyway.
One question, sir.
Yeah.
Dr. Pooja,
yes, ma'am.
Do you start the prednisolone therapy or fluoromethalone therapy immediately, or you allow the epithelialization, and once the epithelialization is there, you remove the contact lens and then you start the therapy?
So we put contact lens right after surgery, and we only start them on antibiotics and lubricating drops. Okay. And if required, topical NSAID, preservative-free and suspension-free. Once the epithelium is healed, then only we start them on steroids. After removing the bandage contact lens.
Well, I have a different thing. I start both on steroids, NSAID, and antibiotics. I give 2 antibiotics. Soaked contact lens also in NSAID, and we start from day 1 because we want to reduce the inflammation. Pain. Yeah, but that doesn't last for that long. We give ocular LS. It can, but I don't think it does. Epithelial healing, it does retard, but the point is that for the pain, the patient is very comfortable. Anyway, I'll be talking about the last talk. I don't know how much time we have, but this is combining CXL with laser vision correction. You can combine cross-linking, and the cross-linking that you are doing is not the full strength cross-linking that you are doing, and these are called as LASIK extra, PRK extra, or smile extra, and you can also combine it for surface symmetrization of keratoconus cases with doing cross-linking in case there is a forme fuste keratoconus. Now, laser vision correction alone, you know that these are the possibilities of having regression and iatrogenic ectasia, and 14 to 33% corneal weakening is there because of the flap creation that has been shown. And the thicker the flap, as you can see, that the weakening of the cornea becomes more. So typically you are weakening the cornea because of two things. One is the flap creation, and the second is the amount of tissue that you are taking out because of the ablation that you are doing. Now, tissue subtraction coupled with creation of the vertical or delamination cuts in LASIK and SMILE respectively, and injury to the Bowman's membrane in PRK, this leads to biomechanical instability and are known factors for the development of ectasia. It is an indeterminate value as to how many patients go into ectasia, but the incidence has fallen significantly with the outcome of the posterior float being looked at by the pentacam, etc., which is there. However, if you have high myopia, thin corneas, abnormal topography, eye rubbing pregnancy, hormonal imbalances in certain conditions, systemic conditions, these are prone to development of ectasia. You can see that cross-linking is well established, and cross-linking came in from dental treatment where the UV light was being used, and from there on the idea of cross-linking came in, and it restores the strength to the cornea. It also increases the flap bed adherence and better tensile strength is given. There have been studies to show that the refractive regression and risk of corneal ectasia are reduced when you are doing corneal cross-linking along with the laser vision correction which is there. Also, there have been studies to show that the epithelial thickness increase is less, which is also implicated in the causation of regression. Now, what are the concerns as to why Shinagawa in Japan almost does all his cases of LASIK along with cross-linking? But there could be some concerns regarding the safety, the side effects of haze and scatter, and long-term outcome of progressive flattening. This is a study by Shri Ganesha's group, where he says that if you have any of these two risk factors, so these are the risk factors, you have to look at the age, high myopia, thinnest pachymetry, residual stromal wet, biomechanical index, CBI, TBI, contributory history, family history, etc. And if he says that any of these two are, then one should go ahead. If there are no risk factors, it's fine. But if there are two of these risk factors, then and he has done a long-term study and he has found no case of ectasia, if I'm correct, in the cases of SMILE that he has done. Riboflavin is used as 0.25 concentration, and you don't use dextran, you use either the saline or HPMC, because that can go on to causing DLK. So this is what is done. You don't put the dye on top of the flap, you put it below the flap, that means in the interface that is there, and you can clearly see a demarcation line which is coming here because you don't want to cross-link the flap. It is not going to contribute in any way whatsoever. This was introduced by Vedro first of all, and this is the cross-linking which is called as LASIK extra. So this is how they actually described. So this is as you go ahead, LASIK flap that has been created. This is a femto that is creating a LASIK flap. Once you have created a LASIK flap, you take the Vibex, that is what they say, and you put it for 60 seconds. You can see that because it is under the flap, it does a good penetration, and because it is in saline, again the penetration is very fast. Because you are not using dextran, you excess Vibex is rinsed off, as you can see here. Once it is rinsed off, you put back the flap, and once the flap is repositioned, you go ahead and you give the dose that you want, which is the ultraviolet light, which is supposed to be given, and that is given on a high voltage, and then you see that this is given for about 60 to 90 seconds, 75 seconds in this case, depends if you are using 45 or 30, I'll tell you what we use. So this is, you can see the demarcation line that comes, and the total amount of energy that you use is 2.7 joules, and what we use is a 30 milliwatt, and what we do is for 90 seconds. So this is what the standard protocol that we use for doing a extra procedure that we have, whether it is a extra procedure for PRK, LASIK, or for a SMILE procedure. And as I told you, we don't do it through the flap because you don't want to cross-link the flap. It doesn't help because it's already a separate and it can cause flap shrinkage. What has been shown by a couple of studies is that the outcomes in number of patients, 90% went on to to come within 0.5 diopters, and it has been shown that it does not cause progressive steepening because it's a suboptimal dose. If it's only a full dose of cross-linking that is given, that you will get flattening, otherwise you don't. Just a case example where you can see these are borderline where you have the bad score, etc. And safety and efficacy have been compared by several authors. So you can see a lot of authors who are giving you great outcomes for LASIK. And then you come on to Smile Extra. In Smile Extra, you just do the normal smile procedure. You will see this is the normal smile procedure that is being done. Lenticule being created, lenticule being taken out. Once the lenticule is out, then you again take 0.25% of Vibex. You can see here, this is going ahead, just putting a little bit of the local anesthetic drops. You're putting the Vibex, let it remain for 60 seconds, wash it out as you can see, and then go ahead and do the cross-linking in this particular case. These are again studies which can show that long-term treatment of Smile Extra in myopia gives great results. Shri Ganesh's study, you can see this is a case, again, borderline. One could go ahead and do the cross-linking. Obviously, it's going to take a lot of patients to actually see whether there's a statistical difference or not. Pooja has just left, but what they have shown is the Smile Extra works much better than a LASIK Extra. As regards comparing of the biomechanical strength which is tested subsequently. But a long cross-sectional study would be required to actually say whether it makes a statistical difference for that or not, since there are no adverse effects that are there, and it gives you a sense of, I would say, whether it's false or whether it's a true, but it gets you a sense of satisfaction that you have in borderline corneas. Sometimes the pentacam overestimates keratoconus or thinks that this has a possibility of going into ectasia. So you can do ahead safely, securely, an extra procedure, and that will give you the additional strength to sleep better at night, and maybe the patient also has long-term benefits of not going into ectasia. Thank you very much for your kind attention. Thank you. So I think with that, we come to the end of the course. If there are any questions, I don't know. Next course is what time? Now? Oh, sorry. Okay. Thank you very much.